Buenas tardes. Vamos a empezar, y ahora que estamos de vuelta de la comida, con la primera sesión de la tarde. Good afternoon, everyone. And we have now an outstanding session that is going to dissect one of the most important and most challenging issues in acute coronary care, that is cardiogenic shock. And we have two distinguished speakers. And the first one is Professor Uwe Zeymer from Ludwigshafen in Germany. And he's well known by us all. He has authored more than 300 papers. Some of them are landmark papers in several areas of cardiology. But in this case, he will be talking about cardiogenic shock, and as you will see, he has been right in the center of several pivotal studies, clinical trials, also in cardiogenic shock. He is actually going to double his commitment in this session, because our third speaker, Dr. Susanna Price, couldn't be here today. She seems to have an issue with our international symposium. So yesterday, the day before yesterday, she called me. She had broken her hand, and I remember that 4 years ago, when we invited her to our previous edition of the symposium, she broke her leg 3 days before the symposium started. So I think I'm not going to invite her again, and I will just tell her as a surprise.
So let's move on to the next topic in cardiogenic shock, is coronary revascularization, and presenting Professor Uwe Zeymer.
Yeah, thank you very much, dear Chairman, dear colleagues. I would like to thank you, the organizers, to inviting me here to this fantastic meeting, to this really beautiful city. And I will have two talks. The first is on coronary revascularization. And these are my conflicts and interests. And I think the biggest one is I'm an interventional cardiologist, so I have a bias towards going to the cath lab and to revascularize patients. And all we do now is based on this shock trial, which has been performed in the last century. And in this trial, only 300 patients were randomized. And this trial is always seen as a trial conservative versus PCI, and this is not true. So this was a trial comparing an early invasive versus a conservative strategy. And as you see here, after 6 months, there was an improvement in total mortality, which was almost exclusively seen in the younger patients. In the elderly, there was an increase in mortality with this early invasive approach, and I will come to this later. I think one of the biggest problems is the small numbers of elderly patients included in this trial. So what was done in the shock trial? Again, this was not PCI versus conservative treatment. 74 patients received PCI, while 51 received CABG. So it was revascularization with either PCI or CABG, and not only PCI. And if you look on the results after 30 days and 1 year, there was no difference on the mortality rate of PCI versus CABG. So both revascularization strategies did the same good job. How does it translate if you really go with PCI in clinical practice? And we have some good results from the French FAST-MI registry over the years. And you can see here that with PCI, clearly you have a better outcome in patients with cardiogenic shock compared to patients without PCI. So it seems that the results of the cardiogenic shock apply to a general population. And we looked in our German registries about the use of primary PCI over the years, and you can see here in the mid-90s it was quite low, less than 20% were treating with early PCI, while after 2005, almost everybody was brought to the cath lab, and the use of primary PCI was almost 90%. And this has been associated with a dramatic decrease of mortality, which was over 70% in the mid-90s. It's now about 40%. So what is of utmost importance if you take the patient to the cath lab to achieve TIMI-3 flow? If we are not successful with our PCI, with our intervention, the mortality is still 80%, so it's as high as we would treat the patient conservatively. So opening up the vessel and achieving a normal flow is for utmost important in the cath lab. And this is not only in our registry data, this has been seen in the shock trial as well. Final post-PCI flow has a hazard ratio of 11, so it's the most important predictor of mortality in this patient population. What's about the influence of the extent of coronary artery disease on mortality? And this is 1-year mortality. And you can see if you have single vessel disease, your mortality is around 40%, while if you have left main disease, it's almost 3/4 of the patient will be dead after 1 year. However, these are very small numbers. So left main, only 11 patients with left main PCI or left main disease were included in the shock trial. So, and these are not contemporary treatment. So we looked in our large ALKK registry with over 2,400 patients with cardiogenic shock undergoing PCI. And here we have 300 patients with left main PCI. And you can see nowadays the mortality is still high. It's still over 50%, but it's not in the range of 70 to 80%. So you can do left main PCI and cardiogenic shock with an acceptable mortality. What's about the success of primary PCI in patients with cardiogenic shock? It's somewhat lower compared to PCI in other vessels. So here, these are other vessels, TIMI-3 flow about 80%, somewhat lower, but not dramatically lower. So our success rate nowadays in patients with cardiogenic shock and left main PCI is acceptable. In hospital mortality, again, is quite high. It's lower in other vessel PCI, and interestingly, but this is really a small number, it's the highest in protective left main, but these are elderly patients with triple vessel disease and a lot of comorbidities. So again, if we do left main PCI, we have to achieve TIMI-3 flow. Here we can reduce mortality, and we have a mortality of 50%. If we are not successful with left main PCI, almost everybody will die. Mortality is around 90%. So I think this is a case for surgery. We don't have that many data on surgery in cardiogenic shock, but I would advise everybody, if you do left main PCI and if you are not successful, discuss it with your surgeon if this patient would not be a candidate for immediate CABG. What's about the elderly? And I've mentioned it in the first slide with the results of the shock trial. Nowadays, many elderly with cardiogenic shock will undergo PCI, and again, these are data from our ALKK registry. And you say we even had 160 patients over the age of 85 undergoing PCI. And clearly, the success rate is almost the same. We have a lower TIMI-3 flow, but 6% absolute difference is not that much. However, mortality is, as you might expect, high in the very elderly, but it's acceptable in the patient between 75 and 84. And this is a comparison to the shock trial where mortality in the patient over 75 years was 80%. So this is not true anymore. Today, mortality is higher in the elderly, but it's not that high. And I think since mortality in this patient population, if you do nothing, if you treat them conservatively, is about 80 to 90%, it's justified to bring the patient to the cath lab, even in the very elderly population. And again, this is the influence of our success rate. So with TIMI-3 flow, regardless of age, you have the best results. So we should try to achieve TIMI-3 flow regardless which patient we are treating. So the next issue is how to treat patients with multivessel disease. And as you see here, the majority of patients with cardiogenic shock will present with multivessel disease. These are data from the ERBB shock trial, from the shock trial, from the shock registry, and from the TRIOMPH trial. What to do with this patient? And you have heard about the strategy in STEMI population already, and there are 4 possibilities: carpet lesion only plus stage revascularization, cabbage, or immediate multivessel PCI. And there are always in medicine advantages or disadvantages, which are shown here. And if you don't know, I think we should do a randomized trial. Interestingly, the guidelines and European guidelines in 2014 recommended multivessel PCI. Here you can see with the so primary PCI should be done only in the carpet vessel with the exception of cardiogenic shock. And this is interesting because if you look on the data at this point of time, which was available, all the data was hinting in the opposite direction. So these are all registry data from different registries. And there was just one registry showing an advantage of multivessel PCI. All the other data hinted for carpet lesion PCI. And we looked in the ERBB shock trial, and we didn't see any benefit of immediate multivessel PCI. If anything, there was an increase in mortality. And we did a meta-analysis of all this registry data. And this is short-term mortality. And you can see here the odds ratio for short-term mortality in favor of carpet lesion PCI was 1.25. So there was no hint that multivessel PCI will be beneficial, and the guidelines recommended it. So it was a time where we were saying, oh, we need some more data, and we initiated the carpet shock trial, where a patient with cardiogenic shock and 2 to 3 vessel disease were randomized to immediate multivessel PCI or carpet lesion PCI, and the possibility to do staged revascularization. And the primary endpoint was straightforward: mortality and or severe renal failure leading to renal replacement therapy until 30 days. And this was a European trial done in 7 European countries, and Holger Thiele was a PI of this trial. And our hypothesis, in opposite to the current guidelines, was that carpet lesion PCI will be superior to immediate multivessel PCI. And we were able to randomize 706 patients, and the primary endpoint after 30 days was available in almost every patient. So we lost just 1 patient during this time of follow-up. And these are the baseline characteristics. And interestingly, and this has already mentioned by Alex, a lot of these patients had resuscitation before inclusion in the trial. So nowadays, about half of our patients presenting with cardiogenic shock will have prior CPR. So this is an important message for this trial. 2/3 had triple vessel disease, and CTO or presumed CTO was present in about 1/4 of this patient. And left ventricular ejection fraction measured at the time of randomization was quite low, 33% and 30%. So these were really very sick patients. And most of the patients' femoral access was the access site, and the drug-eluting stent in the carpet lesion was done in 95% of the patient without any differences between the 2 groups. And 90% of the patients really underwent multivessel PCI in the multivessel group, there were some crossovers. 12.5% of the patient had additional PCI during the indirect procedure, even in the culprit lesion group. Mechanical support, and I will come to this issue later, was done in about 28% in both groups. A lot of these patients were mechanical ventilated, and the timing was about 3 days, and duration of intensive care stay was 5 days without any difference between the groups. So the primary study endpoint, this combined endpoint of all-cause mortality in renal replacement therapy, was reduced by culprit lesion only PCI, and the p-value was 0.01. And interestingly, all-cause mortality was a driver of this reduction in the primary endpoint, and again, the p-value was significant with 0.03. Renal replacement therapy was reduced, but the p-value was just not significant. So both endpoints were in the same direction, and the most important endpoint, total mortality, was a driver of the reduction in the primary endpoint. And if you look on the GFR, not unexpectedly, after 3 days, GFR was lower in the immediate multivessel PCI group. We did subgroup analysis on all the subgroups of interest, and as you can see here, all the subgroups were in favor of culprit lesion only PCI, except the subgroup of the very young patient, but be aware, these were only 33 patients, so the confidence interval is very wide. I don't think there's any hint that any subgroup would have benefit from multivessel PCI. So these were our conclusions, that in patients with multivessel coronary artery disease, culprit lesion PCI reduced the composite endpoint, mainly driven by a reduction in mortality. And so we don't think that current guideline recommendations are valid anymore after this trial, and especially after results of this trial and the registry data, which are all hinting in the same direction. So if you are interested in more details, the trial has been published in the New England Journal, and this brings me to the end. So what's the role of the heart team in cardiogenic shock? Because as I've shown you, most of these patients will have multivessel disease, a lot of them will have left main disease, and the guidelines say it's not mandatory, but I think it's a good idea if you have a surgeon in your house and you have a patient who really might not be a candidate for anatomical reason to undergo PCI, or if you are not successful, to discuss this case with your cardiac surgeon, because there are not that much data on CABG in cardiogenic shock. But if you are really able to bring the patient to the surgery theater, then the results are not that bad. So as in shock, it was almost the same as with PCI, and we have looked up in our registry, mortality is about 30 to 40%, so it's a possibility. Please think on CABG in this patient population. So in summary, I think clearly immediate revascularization is life-saving in patients with AMI complicated by cardiogenic shock, and PCI is a preferred method, there's no question about it. But think on CABG if PCI is not possible for anatomic reason, or if PCI fails, and this failure is seen about 10 to 50% of patients, so this is not a negligible group. And I think after the results of the culprit shock trial in patients with multivessel disease, immediate culprit PCI plus stage PCI is standard of care. There might be always patients where you should think about additional PCI within the first procedure, but these are exceptions. So thank you very much.
Thank you very much. And we have now a few minutes for some questions from the audience. there any micro? Okay. It's arriving.
So, Alex, congratulations to having your paper accepted in Czech. Am I still allowed to challenge you on your conclusion? So you educated us that lactate at presentation, it's the time point to look, and that later lactate measurement is no longer helpful as a predictor. If I recall your slide correctly, there was a difference in lactate concentration at presentation with higher concentration in the epinephrine group. Do you think this might have confounded at least some of the differences observed?
Yeah, I mean, it may. There were a little bit more cardiac arrest in the arm with epinephrine. I mean, this is a play of chance. Then they had a little bit more epinephrine. They may have been more severe, but you saw that the classical parameter, at least, except lactate. Lactate by itself, and this is, I think, shown in the score, lactate alone is not a risk score. You need to add it with 6 or 7 other parameters to have an AUC at 75 or 80. But you saw that other parameters like history of cabbage, and you saw also blood pressure, etc., are really the same. It's possible, but what is interesting is to see over the 3-4 first days, you see that consistently lactate went down, GDF, heart rate. And what is impressive, did you see the heart rate in epinephrine? It's really incredible, and I think when patient is coming with acute myocardial infarction, you better have a low heart rate and really increasing. Now I think the next step is to look on a meta-analysis, putting many data together, but the next step is also to understand why epinephrine was harmful, but more to see why the other drugs are beneficial and whether we can learn more from the other drug and maybe have new drugs to help us. I think now the industry with this kind of trial, they will be happy to enter because they see that the trials are possible, that we can understand things, and we need, I think, urgently some new drugs in this area of cardiogenic shock.
Yeah, I think this is an important point, and I would say it seems that all drugs are harmful, and we would like to see the at least harmful drug in this. So I like your comment in that don't look for the blood pressure, look for organ failure if you are thinking about catecholamines, and not have the reflex, oh, the blood pressure is low, we should use catecholamines, which is really harmful, I think.
Do you think this harmful effect of drugs may be a factor in those trials that looked at the effect of devices, maybe? That the beneficial effect of a device is offset by the harmful effect of drugs?
Yeah, I mean, there are two things I mean, really I'm impressed by the trials that you are doing because the mortality is so high that you feel that nothing can really make a difference between the two arms. And you're right, not only mortality is high because of the disease, but maybe we are adding things that are increasing the number of events, but events that we name non-actionable. This means that it's events that any treatment can make a difference. But despite this, I think our aim is to show for young cardiologists, young intensivists, that mortality is high, but we have some hope to reduce, one, by being more safe with the drug that we are using, and two, by really improving the way we are managing those patients. But I'm sure in the next 10 years we will reduce the mortality, because really we are motivated, and the companies now are entering in this area. That was totally, I mean, there were no studies on cardiogenic shock 15 years ago. There was nothing. It's just, we are sorry they are going to die. And I think here we are really improving things.
In other scenarios, more than the initial lactate is the gradient after 24 hours. But I have a question for Uwe. What is the interpretation of the results of the culprit shock trial? Because, in fact, it makes sense that if you spend more time and more contrast, and you will have more renal failure, not hemofiltration patients, but at least acute renal failure, higher rate of renal impairment, this could influence in the results, because it makes sense that you have all the coronary patency will be good for the patient. And which is the explanation for you in this case?
Yeah, the explanation is that these are very sick patients, and if I do something which is not necessary at this point of time, it is harmful, because, as you said, we need more contrast diet. Inflammation is an important point in this very early setting, and if you limit your action on the carpal lesion, and there's no other vessel with impaired flow or with really 99% stenosis, this is beneficial for this patient at this point of time. This was our approach to challenge the guidelines. You have seen this. They recommend immediate multi-vessel PCI just on a theoretical basis, that it might be, it might be beneficial because of less ischemia or whatever. And we have shown this is not the case. So now we have a clear result which is beneficial for the patient and which is beneficial for the interventionalist. Once you have done the carpal lesion, you can go home and leave the patient alone and go for the other stenosis later on.
Do you think the rate of 20-25% of CTOs could influence? Could you be more selective in?
We have looked for it, and there was no influence on this in this patient population on the overall result. So it's patient with CTO had benefit, and patient without CTO had benefit. So, and you know, we have discussed it a lot to include this patient with CTO, yes or no, in this trial. And the first thing is, in some patient you might not know if this is a CTO, and we said try to open it up, but don't try too hard. So, and this was the case. So it was not that we have 1 liter of contrast diet to open up the CTO. This was reasonable in my opinion.
Alessandro? Alessandro? If I can just echo what we heard, I think for the young generation, managing those patients is different from what we were doing. What we were trying to do is to have the patient surviving by any mean in the first minutes. And I think the young generation, everything they will do, they will think 30 days, 90 days. And by minimizing anything that is not harmful is beneficial in this condition. And I think this is good, because we should think on a longer term period and not only be happy. I mean, I see when we are still managing patients, the resident is happy when he sees a little bit of increase in blood pressure. And we showed this increase
disappear. No? You want to survive your own call.
Exactly. and arrive at 8 o'clock and give the patient at 8 o'clock.
I think we have a question from the audience, yes. From a surgeon actually.
Yeah, I think I'm the only cardiac surgeon in the room. That's why I would like to give a comment to the excellent presentation of Dr. Zeymer concerning the patient in cardiogenic shock. Of course, at first I want to say I'm very happy when the cardiologist is thinking on cardiac surgeons and calling them. However, a patient in cardiogenic shock is also a very difficult entity for us, and sometimes even if you call us, we will refuse. I say sorry for that. I think this is a very it's a hard team decision. It depends on the age of the patient, on the height of the myocardial region, of the ventricular function, of the lactate levels, and at the end also our results are poor. We are approximately 50% mortality, and most of the patients have to be weaned. It's not possible to wean them from heart-lung machine, so we have to install an ECMO afterwards, leave the chest open, and so on. So if it's a patient in good biologic condition, it makes sense to operate on him, because it's not the problem to make the bypass surgery, it's a problem to wean him afterwards from a heart and lung machine, because you have a perfect revascularization, but you will end up with myocardial edema, with a bad perfusion of this ischemic muscle. And so if the patient is over 75 years of age, the troponin levels are extremely high, and also the lactate level, it makes no sense. But if the patient is younger, the troponin is not really exaggerating high, it makes sense to operate. If it's not possible, to go for PCI. But also for us surgeons, PCI is the first line of therapy for a patient in shock.
I think we can wait before you answer, because we have another surgeon in the audience, and maybe wants to comment something.
It's good, one more cardiac surgeon in the floor, but my question is for the panel, because what do you think about VAD implantation in cardiogenic shock? Because I think now everybody wants to put ECMO to all the patients, but ECMO is not a good system for recovery heart. ECMO is good for recovery organs, but not for the heart. And for example, a young patient with myocarditis, probably for her or him, it's better to implant a VAD system for thinking in heart recovery, unless the multi-organ failure is very, very advanced. But what do you think about that?
Yeah, in patient without myocardial infarction, especially in patient with myocarditis or so, I think it's a good idea. Its limitation, it's certainly reasonable only in a handful of centers, even in Germany. And the next thing is we looked up for the use of what in patient with cardiogenic shock in our carpet shock trial. And there was just one patient in the overall trial going to what after 2 or 3 days. So it's really done really rarely, even in these high-level institutions where they all use
right, because mostly we have myocardial infarction. Yeah, I think you agree in myocardial infarction. Probably AV ECMO, because you are reducing the congestion, although you are increasing the left ventricular afterload, is probably, and you are quick, probably it's the best scenario. Indeed, in myocarditis, VAD should be first-line therapy. Yeah. Would you agree with that? Knowing that, I mean, at least in my experience, myocarditis, sometimes we think it's left, but often it's biventricular, because by definition the virus goes everywhere, and then we put a left, but we have the right ready to be inserted as well. But it's a very good indication. Yeah.
Okay, do you have any? Yeah, we have another question from the audience. Could you? Okay, you have the microphone. Okay.
I have a question to Mr. Zeymer. First of all, I'm really astonished about the fact that since we're using the ABP pump since 20 to 30 years, it must have been a study which confirmed the benefit of such a device. Why now, after so long time, is the opposite? Although I think it is elongating the diastolic perfusion, so normally we would expect any benefit. And my second question is, would you agree to a use of the impeller in the case of very high-risk PCIs, or would you deny?
Yeah, to the last question, there's one trial investigating impeller in this high-risk PCI, and this trial was negative. Also, the company always claims it was a positive trial. This is not the case. And interestingly, FDA has approved impeller for this indication, so I'm a little bit skeptical, but it can be done. There might be cases where it might be helpful to have some mechanical support in these high-risk procedures, which you might not be able to do without any mechanical support.
So, Uwe, just, I mean, I'm getting in between the two questions. So we have a trial, randomized trial, saying that the intra-aortic balloon pump doesn't work, and then we have a comparison of impeller and intra-aortic balloon pump saying that there is no difference between them. So why should I listen to my interventionalists when they say that they want to stick in more impellers? while
No,
they cost about 10 times more than intra-aortic balloon pump.
I'm certainly not advocating them, and I have made my opinion crystal clear that I wouldn't do this, but there might be interventionalists who feel better, and once in a while it's good for the doctor to feel better, but not so for the patient.
Doing the same job.
Yeah, doing the same job. And the same is true for intra-aortic balloon pump. We didn't have any randomized trial. We had the belief that intra-aortic balloon pump is easy to implant, that it might augment something and is associated with a reduction in oxygen consumption, therefore might be beneficial. And still people believe in this, despite the clear results of the intra-aortic balloon pump trial too. So I'm not sure what they need more than such a trial.
Professor Castrati, any thought on this? I was saying that you were putting faces. No? Do you agree?
It's evidence-based. You cannot evaluate the role of a device in individual patients, so it's impossible. But if you feel safer, you can use it, and we are still using the pump in very, very few patients, just because of the feeling better of the physician, not of the patient.
Yeah.
Okay, I think time's up. It's been a fantastic session. I'd like to thank our speakers, especially you, Uwe. You've done a great job in acting as Susanna Price's lecture. Thanks a lot.